Yeah. Hello, good evening, Akwaba. You are all welcome to Let's Talk About Health. We are live on Facebook and YouTube, and tonight is going to be a very good one. Last 2 weeks, we looked into minor ailments and the use of pharmacists in managing minor conditions at the pharmacist or at the surgery. Tonight, we are going to look at one of the very important topics, hypertension. But before I do that, I want to say a very big thank you to Mr. Francis Boachi-Adam, who was one of our resource persons that day. He's a clinical pharmacologist, clinical senior pharmacist based in Kent, and he was with Mr. Andrew Chumesi, who is also a community pharmacist based in London, and they took their time to give us a great insight into minor ailments, medication reviews. Thank you all who gave me great feedback on the program. Tonight promises to be a very important one as well. Hypertension, the silent killer. But before we go into that, just so you know, we are live on Facebook and we are live on YouTube. So don't forget to share, keep liking our page. It's coming to you by kind sponsorship of World Remit and with the courtesy of Omega Live Multimedia. So I hope you all join me. I have got Dr. Robert Khan with me tonight, and I'm not letting him introduce himself because he's actually been here before about a month ago. Yes. And gave us great insight into why COVID-19 affected us so much as Black ethnic minority groups or communities. We are doing this topic tonight because it was apparent that night that hypertension was one of the ailments that is suffered by a lot of ethnic minority groups or Black people, Asian people. So if you haven't tuned in yet, or if you haven't notified your friends and family to join in, please do so. And tonight I always start by acknowledging a lot of you who have been following the show. So I am starting with that. Abba Jacobs of Ran, Yabrefo, said Grave Samson. Thank you all. You guys are brilliant, always supporting me. And you are all members of the Western Region Association of Nurses UK. I also want to appreciate some Morgans who are also always supporting me. Erekwa Mante, Abna Mensa, Marjorie Osei-Jewu, Constance Nipa, and Nana Ani Ahinakwa. I think you are based in London. There are a few other people who are supporting me from all over the world as well, and especially on Facebook. So I have Mrs. Adraina Asari, Mrs. Abna Nyakwa, Manuel Bassau, I think that's a gentleman, Mr. Manuel Bassau, Mr. Philip Arthur, and Mr. George Addy. I cannot say how much, I appreciate you all for following this program, for the encouragement. And the most important thing for me is the feedback I get doing this, because I can tell the impact it's having on people's lives. So without wasting much time, please join me as we go through this all important topic. Dr. Khan, you are very welcome once again.
Thank you, Winnie.
Hypertension, the silent killer. Why do we call it that?
It's interesting. When we're choosing the topic, last time we were talking about COVID, and it was noted that certain people who had certain conditions were more at risk of COVID. We all agree that as we grow older, there are certain diseases that are quite common with aging. If you look on the WHO website, that is where actually I picked that term from, the silent killer. Right. It states there clearly that hypertension, the silent killer, on the World Health Organization website. And the reason it is called the silent killer is it's one of the conditions that you have it, but it doesn't show. There have been so many times when patients have come into the clinic, you check the blood pressure is quite high, and you tell them, oh, your blood pressure is high. And the next thing the person says is that, oh, but I feel well, I'm fine. I don't have any symptoms at all, everything is okay. It is a silent killer because quite commonly there's no symptoms. But then as the years progress, it is causing damage to the brain, to the eye, to the heart, to the kidneys. And then the next thing you know, either the person suffers a stroke, a heart attack, a heart failure, a kidney failure. All of a sudden, out of nowhere, I have had people that I know in their early 50s suddenly suffer stroke. And the reason was that they had undetected blood pressure for quite a long time at the time of diagnosis. So it is a disease that kills. However, more importantly, it is the causes can actually be prevented, or people can do something about it, which is why it makes it so important for us to talk about. Because I find it a tragedy if there's a condition we can manage quite well or even prevent, and yet people don't take it seriously. And then you end up your life being cut short, or you suffer some unfortunate consequences as a result of it, when you could actually have done something about it.
Absolutely.
That's right, yeah.
On that note, I think at some point I am going to use myself as your patient and give an account.
That'd be brilliant.
A near-miss account of what encounter I had with hypertension, so people have a clear picture of how silent it can be. So what really is it? How do we define it? What actually goes on with hypertension? So the word hyper means high. Tension usually comes from the word pressure or force. Now everybody knows the heart. If I can get the diagram of the heart on the screen, everybody knows the heart. And we would hope so. That everybody
knows where the heart is. A great majority of people. Yes, that's a very good diagram of the heart. And if you look at the heart, you can see some arrows showing. The heart normally has a left side and a right side. So as I'm sitting here, this is my left side. This is the right side. On the diagram here, the right side is to my left, and the left side is to my right. Now, when you look on the left side, you would see that there's an upper chamber labeled left atrium, and then a lower chamber. You don't see that that arrow there, but it is left ventricle. Okay, and then you've got the right ventricle, which is the right lower chamber, and then you've got the right atrium, which is the right upper chamber. This is the heart sliced into two, and then you can see this vessel, or like a tube or a pipe, blue one going up, and then another one, the big red one called the aorta. Are you with me? The heart is the pump of the body that pumps the blood through your arteries. Now, anywhere you see blue, especially when you're dealing with circulation, it means that it's carrying
deoxygenated.
That's right. It's carrying a vein is normally labeled as blue. When it comes to the heart, interestingly, the blue one is indicating something that is bringing in. If you see the red here, the vein, written pulmonary vein, it is actually
to the right side of our
screen. To the right side of our screen, you would see pulmonary vein. This is where a small reversal occurs. Normally, blue indicates a vein, red indicates an artery. When it comes to the heart, you would see that a vein normally carries blood devoid of oxygen, but the pulmonary vein
is the only vein.
Is the only one carrying oxygenated blood. So on the left side, if you look at the left atrium, it basically collects blood from the lungs, blood that has been enriched with oxygen. And then it passes through what we call the mitral valve. A valve is like a flap that separates the top chamber from the bottom chamber.
So it prevents backflow.
It prevents backflow. Well, you're a cardiac nurse, so you help me there. That's right. So the left side of the heart mainly is to deal with pumping blood to the rest of the body through that big tube, the red big tube there. And then the right side of the body then receives the blood that has been used up in the body, and then pumps it to the lung so that fresh oxygen gets into it. Now, the whole idea of the pressure is that if you compare that to maybe a great majority of people who come back from back home, when you build buildings, now we have water tanks, don't we? Which sits
going all the way up,
with the pipes supplying. The heart and the circulation is almost like that. You've got taps that are flowing from the pump. The pump must be able to pump the blood at a certain pressure into the body. The pressure in the aorta, or the pressure in the blood vessels, is simply as the blood is flowing, it exerts a force on the walls. Remember that the walls are a bit elasticated, so it's able to stretch when the heart pumps the blood into it, and then it contracts and pushes the blood along. Now that motion generates a pressure. So there's pressure in the aorta. The further away you go, you realize that the pressure reduces slowly away from the heart. It is almost the same if you've got maybe, say, a river or the sea that opens up into a river. At the mouth of that sea into the river, it is more turbulent because there's a gush of flow. And then as you go further downstream, it becomes a bit more still and the pressure is lower. It is the same system that runs. Now, as we grow older, the blood vessels get a bit rigid so that the elastic within the blood vessels are not able to expand as much as it should. Now, that in itself naturally generates a pressure. Pressure in the blood vessels have to be within a certain range to allow the blood to flow effortlessly without damage to the blood vessels themselves and to the organs and the tissues that the circulation is supplying. So when we talk about normal blood pressure, that is the pressure within the blood vessels that allows the blood to flow effortlessly without any damage to the cells. The cells. But as I said, as we grow older and sometimes as a result of disease, this pressure goes quite high. When it goes high beyond a certain range, then we say the person has high blood pressure or hypertension.
I really like the fact that we are doing this illustration. Because it's very important, we know, and we didn't even mention the heart is on the chest here. It's very, but the left side normally. Because a few people have congenital conditions where the heart is on the right side.
That's right.
And these people would know. But for the health professional, because I like to look at the whole picture of, you know, in case of a cardiac arrest, for instance, that is all we are trying to do, to compress the chest wall, so we get enough pressure on the walls of the heart to be able to push some blood into circulation. So if you're watching, that is what we do, and the reason why I really like this kind of illustration, not just because we want to show the picture, but the importance of knowing how important the pressure in the heart itself, a normal heart, is. So I think that is quite clear. Obviously, it is very technical, but simply put, is just how a normal tank works and tries to push water around the house. You know, and if you get that, you're on the right track. But just know your heart is usually on the left side of your chest, and you need that pressure for it to be able to pump around the whole body. So why is like we know you've described like what hypertension is. Are there any types at all of hypertension?
There are types. Before we come to that, you know, there are what we call stages. People don't suddenly develop high blood pressure. In the great majority of cases, we're just going about our normal life, but then the pressure may be increasing slowly. So as you go to work, you're coming home, as you're stressed, moving around, the pressure is increasing. Usually, you know, we do have a range or a cutoff. In any adult, anybody above the age of 18, whenever you have your blood pressure taken, you would see a top value and a bottom value. The top value is what we call the systolic pressure. The bottom value is the diastolic pressure. Systolic pressure mainly means the pressure in the blood vessels, especially the aorta, when the heart is squeezing or is pumping blood. So if you listen to your heartbeat, you hear kukum, 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 kukum. That essentially corresponds to the heart squeezing blood out. Now, that's right. Once the heart has squeezed blood out into circulation, it relaxes to allow the upper chamber to push blood again into the lower chamber. During that relaxation phase, there's also a pressure in the chambers and in the blood vessels that correspond to what we call the diastolic, the bottom value. So when you take your blood pressure at home, in clinic, wherever, we would always give you a value at the top and a value down below. The value at the top, we try to maintain that below 140 for anybody who is an adult. And then
so what, from 18 years
and above, because that's the criteria. Any adult is 18 years and above. Anybody below the age of 18, we would have a set of values that we use for what we call pediatric values, basically, for children. So for example, a child of 11, we would expect a certain range of blood pressure up to the age of about 17. But from 18, you're considered an adult. So then that criteria applies from 18 all the way to whatever age that we're dealing with.
Okay.
So
does this take into account your size at all, or it doesn't really matter? Because I mean, like these days we do come across kids who are like almost, big and almost like adults.
Yes, I think that where the size comes in, it depends on the cuff that we're using, basically. Right. Okay. This is where the differences are, because if I've got let's say a skinny 17-year-old or a skinny 16-year-old, I'll use a pediatric cuff to check the blood pressure. But if the child is quite chunky, then a pediatric cuff would give me an abnormal value, or it would underestimate the blood pressure. Yeah. So I might have to use an adult cuff to get a reasonable blood pressure from that child. But usually adults are adults, irrespective of size. If somebody has a bigger arm, we would use a bigger cuff. So it almost like normalizes what we're doing.
I wanted that to come out because we know these days a lot of people like to monitor their blood pressure, which is a good practice. Yeah, but just so they know, if you
the differences,
are a adult, you would probably be better off getting more accurate readings using a smaller or a pediatric cuff than using like a big adult cuff, for instance.
So in talking about the stages of hypertension, remember that if somebody is diabetic, we even try to get the blood pressure lower. So for diabetics, we would say that the systolic should be around 135 or below. And then 85 or below. It's simply because somebody who is diabetic has a higher chance of developing cardiovascular events. So their risk of developing a heart problem or vascular problems is much greater. So you want to keep the blood pressure much lower, and especially for the sake of the kidneys as well. So you don't damage the kidneys. So we try to keep their blood pressure a bit lower. But for somebody who, for example, does not have any other medical conditions, we would aim to keep the systolic or the top value below 140 and the bottom value below 90. So that then leads us to the staging. So we have stage 1. If your top value remains consistently between 140 and 159, and the bottom value between 90 and 99, then you're dealing with stage 1. Okay. In a great majority of cases, if the person doesn't have diabetes, doesn't have any other problems at all, they're fit, then you would want to monitor. When we come to management, we'll talk about that. And then we have stage 2, where now you have a range between 160 top value to 180 top value. And then the bottom bit would have to be between 100 to 120 or 119. That's stage 2. Okay. And then you have what we call severe hypertension. That's where you have the systolic more than 180 and then the diastolic more than 120. At that point, you would realize that if the person had had the hypertension for quite a long time, it would already have started making changes. And this is where we tend to start picking up. Somebody might go to see the optician. They'll start saying that, oh, I can't read small print. My vision is becoming blurry. I'm getting headaches. Or they might have a work medical, for example, or a private medical, or maybe a church community occasion, and somebody's checking the blood pressure and they are told, oh, your blood pressure is quite.
A lot of the time it's accidental.
It's accidental. We pick it up accidentally. So they go to the optician. The optician says that, no, I can see changes behind your retina, which indicates that maybe your blood pressure is high. Why don't you see your GP or the practice nurse? And then when they come in, you see the blood pressure is persistently high, taking over several days. And then we have what we call malignant hypertension, which is where the systolic, the top value, is more than 200, and the bottom value is more than 120. That tends to be an emergency anyway. If somebody comes in with around, say, 180, 110, and at that time, maybe they have what we call subconjunctival hemorrhage, they are bleeding into the conjunctiva, or maybe they have edema, you see the eyes quite swollen, the thin layer of the eye quite swollen, or they have persistent headaches, they have a chest pain, they have palpitations, shortness of breath, then you know that they are developing what we call end organ damage. So the pressure has gotten to the point where it's affecting the brain,
and
the eye.
These are changes which would be,
gradual over time. Over time, when you start seeing those changes, for example, changes in the eye, changes in the kidney, changes in the heart, changes in the brain, it doesn't happen overnight. That is why we call it the silent killer. It takes years. It means the person has been having warning signs, but they ignore it. Many of us would have a headache. What do we say? Oh,
we actually
beautiful
have a blood pressure
machine here. Yeah. Interestingly, I wanted to bring one along to use as a for demonstration.
For demonstration, yeah. Obviously, so there's technique in checking as well.
That's right. Yes.
And if you are diagnosed as being hypertensive, the normal thing is for your GP or your nurse practitioner to show you the correct way to use it, because these days we are all buying one of them to check. And
in fact, on YouTube there are excellent videos that teach you how to use a blood pressure machine and how to even interpret it to the layperson. So it is quite a useful resource. We'll come to that when we talk about prevention, for example. So these are the stages of hypertension and the types. Basically, you have what we call essential hypertension.
So the malignant hypertension is also a type.
It's it's a stage.
It's a stage.
So it starts slowly, and then the pressure increases. So that's the stages. And then you have the type, what we call primary, primary hypertension, and then secondary hypertension. Primary mainly, in 95% of cases, most people have what they call primary hypertension or essential hypertension. Usually there's no cause. It just happens as we grow older, lifestyle, diet, smoking, alcohol, these things causing the blood pressure to slowly rise.
And then with the predisposing
factors. Then we have secondary hypertension. Secondary means that there's a cause. So somebody having diabetes, for example, they may not have started off with hypertension, but as a result of the diabetes, they develop hypertension because of the effect of diabetes on the blood vessels. There are some people who are on certain medication, for example, steroids. Steroids have a way of increasing the blood pressure because they retain fluid in the body. There are some people who, for example, take drugs, cocaine, amphetamines, methamphetamines. There are certain medications like cyclosporins that we use for rheumatological conditions. And certain conditions like lupus, certain kidney diseases as well would cause the blood pressure naturally to rise. When that happens, we say that it's secondary hypertension. And then, apart from that, then you have hypertension in pregnancy.
I think we will take time to look at that.
That's right. Hypertension in pregnancy, which is basically, a lot of times you have a woman who already has high blood pressure before they get pregnant, or they develop hypertension in the course of the pregnancy. We'll touch on that briefly before we leave here. And then we have what we call white coat hypertension, where that's
white coat hypertension.
White coat hypertension. Basically, there are some people who they check the blood pressure at home, it's fine. The thought of entering into a GP surgery, whether it's the nurse or the healthcare assistant who is checking the blood pressure, or the GP who is checking the blood pressure, the BP just goes up. It just goes up as a result of anxiety. So we call it white coat. The term white coat is because many years ago doctors used to wear
white coat.
Their white coat. So as soon as people see that, they get anxious, and then the pressure goes up. A good way of telling the difference is asking the person to do blood pressure readings at home, in the comfort of their own home. You see, the readings are always good, but when they come to the surgery and you check it, it is always, the systolic is always between 10 to 20 millimeters of mercury higher, and the diastolic is about 10 millimeters of mercury higher than what they have at home. Then you know you're dealing with possible white coat.
And with the white coat, can it develop into full-blown?
Not necessarily. If the person doesn't have,
just due to anxiety.
Just due to anxiety, And sometimes we would strap one of our devices on for the person to do a 24-hour, what we call ambulatory blood pressure monitoring. And then when they come back, you see the readings are normal. Basically, and you would reassure them.
Just to rule everything
out. So those are the types, main types of hypertension. Primary, secondary, then hypertension in pregnancy, and then white coat hypertension.
Wonderful. I think we cannot progress talking about hypertension without looking at the flip side of it, which is hypotension. So where does that stand as well? I think we can have a look at both sides, because there will be people who also suffer with hypotension rather than hyper. What happens in that case?
Hypo basically means low. Hyper means high. So remember I said that there's a range of blood pressure the body needs or the heart needs to pump the blood safely around the body. If we say that for hypertension we want to maintain the top value at 140, then we don't want to go below 100.
Right.
Because if the top range. For the top range. So anything between 100 and 140 is safe. There are some people who still have a systolic between 90 and 100. Some people naturally, especially when you take top level athletes, can have a bit lower blood pressure, and they're fine with it. If somebody's systolic is below 100 and the diastolic, for example, is below 60, and they realize that anytime they stand up they feel dizzy, they feel giddy, okay, then you're dealing with hypotension. Postural, what we call postural hypotension. As soon as the person moves, stands or starts walking, the pressure drops suddenly, and then they feel as if they're fainting, wanting to pass out, basically. So low blood pressure itself, something must be done about it. There are people who develop low blood pressure as a result of the medications they're taking. A typical example is the beta blockers that we, bisoprolol, propranolol, medications like this, that controls the heart rate and the strength of how the heart pumps, and as a result reduces the blood pressure. When that happens, then we might have to look at the medication the person is taking.
Exactly. And for those who follow this program religiously, the last time we looked at the importance of medication reviews, and this came up, hypertension, and a lot of us, black minority ethnic groups, we do suffer with hypertension, knowingly or unknowingly. And it was apparent that we should know the medication we take, and we should know the effect as well. And the reason why it's important to have periodic reviews of what medications, because even though we are having it for hypertension, at some point, for some people, they may have been taking it for a long time, and then
the pressure drops.
The pressure drops, and suddenly, it's a different condition altogether. So very important. If you have just joined us, we are live on Facebook and YouTube, and we are bringing you this by kind courtesy of Omega Live Multimedia and by the kind sponsorship of World Remit. World Remit, if you haven't used World Remit, is the safest way to send money to your friends and family back home in Ghana. Very affordable, very, good service. I have used them so many times, and it's absolutely safe and reliable. So please do use their services and let them keep sponsoring Let's Talk About Health. I think I forgot to mention my name earlier. I am your host, Mrs. Winnie Ohinikisi, and thank you for joining in. We have been looking at hypertension. We've looked at where the heart is. It's always important to me. You know where your heart is, on your left side of the chest. And we have looked at how the heart works to generate the pressure. And we have looked at the types of hypertension as well. These are all very important because if you are diagnosed with hypertension, you will need to know what type you are in the management of your condition. So what causes hypertension, Dr. Khan?
As I said, if you look at primary hypertension or essential hypertension, we said in 95% of cases, the cause is unknown. As we grow older, aging plays a big role. If you look at it this way, the younger you are, the more softer your blood vessels are. The elastic within the blood vessel walls, they can expand and contract. As you grow older, the blood vessels get older. They get more rigid. Now, if you have
just by the normal aging
process, it gets a bit rigid. Now, if you imagine it this way, if you've got a flexible tube, fluid flows through it easily. If you've got a rigid tube, it takes a bit more pressure to pump the fluid through it. The heart also ages, and as a result of our diet and lifestyle, sometimes you also do have cholesterol or lipids lining the inside of the blood vessel. And the illustration I always use is if you look inside your kettle or your flask, you see scales in there. It is the same, or an old pipe
Yeah.
You would always see lime
Build
scale,
up.
a buildup of lime scale. It is the same with the blood vessels, especially the blood vessels that move away, that supply the heart. As you grow older, you would have this lipids lining it, making it narrower. Now, if it's narrow, then what do you have? You know the left side of the heart that we talked about, that's the pumping station. It tries to pump the blood under normal pressure into the aorta or the big vessels. If you've got a narrowed tube, then what it means is that the left side of the heart needs to work harder to pump the blood through the same tube. And by doing so, it has to generate a higher pressure to be able to overcome the resistance in that tube. So then with time, the pressure starts increasing. That's why you tend to see that in a great majority of cases, most patients that have developed high blood pressure are older. So people above the age of 45, for example. I had one patient who said that, before the age of 40, I didn't see my GP. Between the age of 40 and 50, I was seeing my GP about once a year. By the time he hit 50, he was now seeing the GP about 2 or 3 times a year. And that's the logical progression.
Tell straight away,
We can tell straight away that as we grow older, we joke that life begins at 40, isn't it? However, after the age of 40, you see most of the cells, most of the body parts, most of the tissues start getting older. So whilst life begins at 40, the body tissues start deteriorating slowly from that age onwards, and your blood pressure starts creeping up slowly. And then we talk about ethnicity. It is noted, very common, that people of African Caribbean origin are at high risk. Actually, we have 3 times higher the risk of any other ethnicity when it comes to high blood pressure. Why? It is genetic. I cannot explain. Family history. If you have many family members who have hypertension, just like diabetes, it runs in families as well, then you are also at risk of developing it. Alcohol, excessive alcohol intake. What alcohol does is that it affects the blood vessels. Alcohol as well as cigarettes, they harden the blood vessels. So if you imagine, if your tubes are getting hardened, then the pressure in it is going to go up.
And you know the analogy you made using kettles and stuff. One very good observation I made, because I have done talks on heart attacks. And when I look at a chip pan, just look at your chip pan
goodness
at home.
Me, don't go there.
And that it's a very good one. That scares me a lot
when I look at
the deep fryer. Take time, look at your deep fryer. And look underneath your deep fryer or in the corners where there is build up. And when these blood vessels are eventually unblocked through procedures like what they do in primary stenting
when you're doing
and stuff like that, I see a chip pan and I'm like, this is bad news.
It is.
So take time, look at your chip pan at home, especially when you haven't changed your deep fryer, even you've not changed the oil for a while, and look how it accumulates, builds up and cuddles up. That is exactly what it's doing. So anytime you are having all these oily stuff, it's taking that you are building up and closing all the holes in your blood vessels. So it's a good one to look at. So I have a few people joining in already. Ekuya Danswa is always with me. Efua, amen. Eddie Mensa, I always say bring questions. It's the questions that we need. But thank you all for tuning in anyway. Eddie Mensa, same me, Pa Mensa, chief cheerleader. Thank you, Pa. Louisa Boateng.
Yes, that's my mate.
Oh, that's your mate. Thanks, Louisa.
Dr. Louisa,
Dr. You are Dr. Louisa. Then get ready.
I'll bring her. Yes.
Okay. And Dr. Khan, thanks for sharing this knowledge. Patricia Isufi Ado, welcome, Dr. Khan. Greetings from Gravesend. Andrew is watching and says, great show. Thanks, Andrew, and thank you, Francis, Mr. Bwachi Adam. You were all great 2 weeks ago, and thanks for all the feedback and for even taking time to go through some medication reviews with people who contacted me after the show. So if you are especially in Ghana or places where you cannot get people to review your medication, please contact me through Messenger, and I will definitely get them to review your medication. So it was wonderful. I really like the feedback bit, because that is the whole point of the show. George Akumia Ankra is greeting you from Ghana, and he says very educative. Albert Achamfo, lovely program. He is with Nightingale Nurses.
Yes, that's right. Yeah.
Nightingale Nurses. I'm waiting for you guys to start featuring again, you know. Greetings to you, Winnie and Dr. Khan. Thank you. Adwa Dufie Ousu Banahene says, well done. Dr. Sapia is watching. Augustina Bwedu, I'm waiting for your questions, guys. Host, you look amazing. Oh, thank you. For the first time, I decided to go back home to Ghana, you know, and to portray all our rich culture. So expect more of these. And this was actually donated to me by my very best friend, Nana Sarah Amofapia. She said, you have to look amazing in our African print, Winnie. And I am flexing today. It's a nice day out there. Thank you, Nana Sarah. You know I love you a lot. Augustina is saying, I look amazing. Thank you, Dr. Khan. Can you explain the relationship between hypertension and diabetes? And we will take that on. It's a very important one, because these conditions, and even hypertension and kidney failure. So we will touch on that. If I don't, just remind me, Eva Newlove is one of our presenters, and she's with that. Hetty Century Edwards is watching from the US. Hetty, thanks so much for joining in. Looking lovely, Winnie. Oh, thanks, Eva. Patricia Esilfi Ado, Philomena Chumesi, Kojo Che Mensa, good show. Abba Jacobs, I have a question for Dr. Khan. Why is it that patients stay on antihypertensives for years without taking them off it, even though their BP starts reading normal? Well, I think that's a good one.
I can answer that quickly. It's very simple. The reason your BP has gone down is because you've been put on medication. So if you take the medication off, the blood pressure slowly starts creeping up again. And actually, you know, the diagram that we used, we said that if the pressure is high, then the heart is working harder. The medication that we give does two things. One of them, some of them work on the muscles of the heart to relax the heart muscle so that it doesn't work too hard. The others work on the blood vessels, makes it softer so the heart can effortlessly pump blood through it.
You see, that's why I always make them go through the anatomy or the physiological process happening. So you have a very good understanding.
I use that in clinic quite often. And patients like the illustration when they know why they have to take the medication and the damage that the blood pressure is causing to the heart, to the eyes, and to the brain as well. Sometimes you would stop the medication and then you realize that the pressure starts creeping up again. Now it's dangerous. If the person is not monitoring the blood pressure at home, essentially they are not on medication and they're also not monitoring the blood pressure, and anything could happen anytime. When the risks are high, if somebody has had high blood pressure before, and you've taken them off the medication, the risk is not gone, the risk is there. Suddenly they hear bad news, they're going through a stressful period, and the pressure just shoots up without any control at all. My personal advice to my patients is that even when the blood pressure has gone, unless it's gone to hypotension, in which case we would take you off the medication and then monitor. But if it's keeping it within normal range, then we can put you on a much smaller dose just to keep the pressure taken along.
And is there other times where the medication will have to be switched to other
medications? That is the whole essence of medication review. Every medication has side effects. So for example, if you take something like amlodipine, one of the commonest side effects is swelling feet. So you start patient, and quite commonly that is what we tend to use in Afro-Caribbeans because it's more effective.
But why is that actually? Is it just the chemical composition of the drug, or why is it the first line of drug choice for?
Well, from all the evidence out there, it is said that if you know, hypertension is quite difficult to treat in the Afro-Caribbean population. A great majority of our people would end up on either 2 medications or 3 medications to manage their hypertension, which is why it is even important, if somebody is on one medication and it's maintaining it, don't come off it. Because once you come off it and then your blood pressure then goes out of hand, you would end up on 2 or 3 to then manage it properly. So if, for example, you're developing side effects to a particular medication, then we would change to another one. But it's noted that amlodipine tends to be more effective in our population than the other groups of blood pressure medication.
Right.
Yeah.
Okay. And the relation between that and diabetes?
Diabetes, and you know that diabetes affects the small blood vessels, especially, quite commonly. Not just the small blood vessels, but also the bigger ones. It causes the blood vessels to become harder. And then again, diabetes has a way of causing what I don't like using too many technical terms. You know, atherosclerosis.
Yeah.
It makes the blood vessels harder. And brittle, and makes it easier for example, lipids or cholesterol to line the blood vessel.
Yeah.
So we tend to see that if somebody has diabetes, then with time, they start developing cardiovascular side effects or effects on the heart and circulation, which is why even when you start a patient on diabetic medication, sometimes they don't have hypertension, but we will put them on a small dose of Ramipro, for example, to help manage blood pressure and then help and protect the kidneys.
The kidneys
as well.
Right.
Yeah.
Yeah, and people with hypertension also tend to suffer with kidney disease.
Yes, kidney disease as well.
And I remember when I had the renal nurse here, she highlighted the fact that the heart's supply, a fifth of that supply goes for the kidney alone.
Through the kidney,
Yeah, so it's hardly surprising when you're having problems with your blood pressure. The kidney also gives a hint because it's not happy that it's undergoing that. I did mention earlier on in the show that I was going to use myself as an example, and will be your patient for today and give you a little account. So on this note, I hope you are all listening. Somewhere late last year, 2019, I felt unwell. I think this is just touching on some of the side and symptoms. I just felt short of breath, lethargic, and because I've had anemia in the past, all my mind was focused on anemia. I must be anemic again. I am so tired, and it was really affecting me. But then I thought it can't be any more than just the anemia. So what do? I took some anemia tablets to bring iron tablets to bring my hemoglobin up and all that, and it was not making any difference at all. So one day I decided to see my GP. Went, they did an ECG, did the bloods, but my focus was just on the blood results. So anyway, as a cardiac nurse, you would have thought that I would just look at the ECG and see what was going on. I wasn't interested in that at all. I was interested in knowing what my HB was. So come evening, I have a call from the GP, and they said, you have ischemic changes on your ECG, as in your heart is really struggling.
Yeah.
So I said, and the GP was very concerned. And I could have looked at the ECG, but I really wasn't interested.
Yeah.
You see, the problem is sometimes when we are health professionals, we think this cannot happen to us. You are in denial that this will never happen to you. It can't be me. So anyway,
we are the worst patients.
We are the worst patients.
Yeah.
So if you are listening, please listen to your body. I always say this on this show, very important. So what happens? The next minute, an ambulance is at my door because of the ischemic changes on my ECG. When they checked my blood pressure, it was 235/135.
See.
And so they repeated the ECG. This time, I looked at it and I had T-wave inversions. I mean, obviously, if you interpret ECGs, you know that is ischemia going on in the heart. So I end up in an ambulance, end up in A&E. They checked my blood pressure, still high, gave me amlodipine. But then, because they did a blood test called troponin to check for heart attacks, and that came back negative, I was discharged home. But good enough, the GP checked on me, called me the next morning. I said, I'm home. And they were like, how are you home?
Less than 24 hours.
Less than 24 hours. Yeah. And I think it's probably because she's a nurse. She would know how to manage herself.
No.
So the GP said, I want to see you again. Repeated my blood pressure again, 130 over 230 over, it was really very high. And then an ambulance was called from the GP again. So in just the space of about 2 days, I was in the ambulance 3 times. And all I felt was just feeling unwell, feeling short of breath. But it was almost progressive. I was struggling to go up the stairs at home. Yeah. See, so these are some of the things, and that is one of the inspirations for doing this, because I thought if it can happen to me, it can happen to anyone.
And you are a health professional and a cardiac nurse. And anybody would think that, because you're a nurse, you should know better. But we're humans. And a lot of times you might think that, it cannot be high blood pressure. Yeah. It might even not cross your mind at all. We always try to find reasons why we're feeling a particular way and not really check the blood pressure. Now, blood pressure of 235 over 100 would easily cause stroke in somebody. Somebody could easily develop brain hemorrhage as a result of that kind of a blood pressure. So you were fortunate.
I was
Many
fortunate.
People would not be that fortunate with that kind of blood pressure. And that is why it is called a silent killer, because you wake up in the morning, you're going to work.
You may not even wake up.
You're just going to work normally. The next thing you know, boom. You've just passed away.
And so please take these sessions seriously when we have the experts here, and take time to review, watch all these shows and get the practical information, the patient stories. All this is coming to you by Omega Life TV with the kind sponsorship of World Remit. So please take advantage of these sessions when your professionals come here. And on this note, Dr. Khan, I thank you so much that you have taken keen interest to support me immensely, and to support Omega Life as well in doing this health show. So I have a question from Samuel Adebiankra. And Sam, how are you? It's been ages. I hope you are well. He is saying, Dr. Khan, patients on antihypertensives and alpha blockers for urinary, he's got a health background, you see, so he knows what he's talking about. Alpha blockers for urinary problems who experience low blood pressure and fainting episodes brought to the hospital and medication discontinued. But as soon as they get to the community, the GPs put them back on those medications. So
I think it needs to be reviewed. The commonest alpha blocker is mentioned is tamsulosin. For example, when a guy develops prostate problems and peeing becomes a problem, you would put them on that medication to help ease the flow. Now, tamsulosin, yes, I agree. You know, when you take beta blockers, just like alpha blockers, would act on the cells, on the blood vessels and the heart, and they can reduce the blood pressure. So if the blood pressure goes low, if the person is on alpha blocker, I probably would monitor, because you've still got an alpha blocker there, which can still control the blood pressure. So you don't put another blood pressure medication in. If the person is well informed, I normally would advise them to buy a blood pressure monitor at home, and then regularly check the blood pressure to make sure that it stays low. Because there's a medication in there that is bringing the pressure down anyway, so they don't need a second one in there to control it. They will end up having hypertension, the blood pressure going quite low.
I mean, if people are being monitored by surgeries properly, they will give you a diary, isn't it, to keep on monitoring your blood pressure, so you know.
That is difficult for patients to do. I'm telling you. I've got a monitor. I check it. I make an effort to check it weekly, my blood pressure weekly. But sometimes it escapes you. You're so busy that you may not even check your blood pressure the whole week. And that is me with all the knowledge that I have. So what about the lay person who doesn't have the time, nor even the know-how to properly check the blood pressure and interpret the readings that they're having?
So it brings us to a very good question, which is, do we always need treatment for high blood pressure?
Not always.
Not always.
Not always. Again, if you remember the stages that I, even before I go to that, the symptoms are quite important. In the great majority of cases, there's no symptoms. Just as you mentioned that you felt unwell, you felt very funny.
Which could be anything.
Which could be anything. However, as the pressure increases to significant levels, patients start complain of headache. This dull headache that doesn't go anywhere. They would take paracetamol, the headache is still there. Some people say, I've got a migraine, or these days I get a migraine. But they've never been given a diagnosis of migraine. But they're attributing it to a migraine, and they wouldn't even bother to have the blood pressure checked. Some people would say that their vision has become a bit blurry. So when they're reading, and then they would think that, oh, as I'm growing older, I can't read small print, either double vision or blurred vision.
Yeah.
Some people would feel sick, actually, and vomit when the pressure goes quite high. Some people would have shortness of breath, chest pain. Now and again, they would have a bit of chest pain. That is the heart telling them that I'm under pressure here, I'm under strain, I'm struggling. But they won't bother to check. You see people rubbing here, the next morning, gone back to work without a care in the world at all until disaster strikes. Are you with me? So the side effects are, the symptoms are very subtle. And as we said, in the majority of cases, we pick them up. Somebody comes into the clinic, and then we do it opportunistically. Anybody around the age of 40 and above, when they come in, I would always use the opportunity, or whilst you're here, why can't we check the blood pressure? Sometimes people think that, GPs are at it because we need to meet our endpoints. That is why we're pulling patients in. No, we're actually saving lives because you came in with a sore throat, but we'll check your blood pressure and then we'll pick it up. Sometimes we'll dip the urine, and then you notice that you've developed diabetes, which you were not even aware of it. So all these little health checks that we do allows us to pick these things up as well.
Even in developed countries like those of us in the UK who have the opportunity of free healthcare, still going to be checked is a problem. I mean, the dentists see the same problem. We never go and get our teeth checked. Every health professional will probably say that unless there is a problem that needs solving, we don't make it a culture of visiting for routine health checks, isn't it?
You see, that's the whole essence of this program. For people to make it a habit that, you see, you're not invisible. I keep telling people that just as brown leaves fall off a tree, green leaves can fall. So don't think that stroke is only for the elderly. You can be 40 and you develop stroke.
Even younger, isn't it?
I've had some of our people sometimes come in, the blood pressure is quite high. You're referring the person for maybe further investigation. And the next thing they say is that, I don't have time. And there was a patient that I had to be blunt with him. I said, well, if you don't have time for your health, you have time to be in a wheelchair for the rest of your life. And in fact, you have more time to rest at home.
When disaster strikes.
And when I said that, he was shocked at my bluntness. And I said, listen, I'm quite concerned about your blood pressure, but it almost as if you're just being very dismissive about what I just said. But thankfully, he took it a bit more seriously. A bit more seriously.
I think bluntness helps. Because
sometimes it does help. You have to give the shock treatment for people to pay it as it is, for people to pay attention to what you're saying.
Absolutely. And Kwejoche, did you want to say something, Dr. Khan? Sorry.
No, you were acknowledging Kwejoche Mensah.
Kwejoche Mensah.
Yes, that's a fellow pastor.
Wow, wonderful. Thanks, Rebecca Nana Brew.
Yes, she's a nurse in Scotland.
Wonderful. In Scotland. Oh, wow. Eunice Nana Hagan, she is one of the nurses based in London, occupational therapist, and she is also watching us. Olga Armstrong and Gifty Okai, very educative doctor. Matilda Moore. Matilda, she's more now, Matilda. So Matilda is here, and Constance Nipper. Oh wow, that's my mate, and she's watching from the US.
Wow.
So Constance, thanks so much for tuning in. So we will carry on, and we will go through how we ensure normal limits. Is there anything we can do?
Before we come to that, fortunately in this country we have what we call the NHS health check. Anybody 40 years and above, you're entitled to free health check. At least once a year, you should be able to make time. If you tell me that you're so busy that you can't even spare 30 minutes a year to check your blood pressure, have your urine tested, have a blood test done, have your heart checked, have an ECG done, then you must be busy indeed. It means that your health is not important to you. Now, which comes first, as I keep asking people, the chicken or the egg? Is it the chicken or the egg, or the egg or the chicken? Yeah. Which comes first? Is it the horse or the cart, or the cart and the horse? Because if you drop down with stroke or heart failure or kidney failure as a result of uncontrolled blood pressure, who do you blame? That job that is so precious to you, you might not be alive to carry on with that job. Whereas just 30 minutes spent at the GP surgery could prolong your life so that you can do the things that you want to do. Are you with me? So my advice would be, book an appointment with your GP or the practice nurse. When you come in, now we're trying to make it a one-stop shop. So when you come in, at least you see the practice nurse. Certainly in my surgery, we're trying to implement that because people are so busy that they don't have time. So when we're booking your appointment, if you need to see the GP, you can at least book a double appointment, discuss what you need to discuss with the GP, and then see the practice nurse. And just to have your MOT before you leave.
Full checks.
Your full checks before you leave the practice, because it could be a lifesaver. Now, once you come in and we check the blood pressure, we don't start people on medication straight away, unless the person has been monitoring at home and they realize that the pressures have been quite high, in which case we do some blood tests, do some investigation, and then start you on medication. But otherwise, you come in, say maybe first time you come in, I check the blood pressure, it's high. I would allow maybe a minute or two, recheck the blood pressure again, and then recheck it again 3 times, and take the lowest of the values. If it's quite high, and at that time, maybe there's no headache, there's no chest pain, there's nothing concerning at all, it's not an emergency. I may refer you for blood test. These days, I've been encouraging people to buy a blood pressure monitor, similar to the one that you have there. Now, the blood pressure monitor, even a very expensive one would be about £50. How much does a Venezuelan hair cost? Or Brazilian hair, how much does it cost?
Yeah, good point.
When you do your hair, how much do you pay for it? That Xbox you buy for your son, how much is it?
Absolutely. It's just misplaced priorities.
If I go for a shape up at the barbers, that's a cool £13 a week. So why don't I shave myself for a month and then use that money to buy a blood pressure machine? I'm just talking about priorities. Which is more important to you? The carton of beer sitting in your house, or a blood pressure monitor that costs £30 that could save your life. If you have that at home, then I would ask you to monitor your blood pressure morning and evening for 4 to 7 days, and then you come back. Now, by the time you come back, you would have done your blood test, basically checking your full blood count, checking the kidney, screening you for diabetes, doing other tests as I deem fit as well. If I sense that maybe the pressure is too high, you've been having symptoms like headache, maybe chest pain, maybe palpitations, then I may recommend an ECG, which is a trace of the heart, to look at the rhythm and the electrical activity of the heart at the same time. So by the time you come back in a week's time, the ECG report is ready, your blood test is ready. Urine dipstick, we do it right there in the surgery, instantly, looking for blood, looking for maybe infection, looking for other things. Are you with me? So you have your mini MOT. At that point, based on the readings that we have, if we think that the blood pressure is quite high, we may do 1 or 2 things. If you're much younger, much fitter, okay, we know that 1, you can manage your diet. 2, maybe you're very active. 3, you can lose the weight. And you're disciplined enough to do things.
Brings us to the lifestyle changes.
Yes, then I may recommend lifestyle. Again, it depends on whether I'm dealing with stage 1 hypertension or stage 2. So if your systolic, for example, is persistently above 160 and your diastolic persistently above 100, then I'm not going to waste time, because that's too high. Then I may start you on some medication, and then we'll monitor, and then you do your lifestyle changes and whatever. If at some point we realize that lifestyle plus the medication is bringing the blood pressure too low, we can stop it. And then you just be on lifestyle. So the answer to your question is that it's not always that we put patients
on medication.
It depends on what stage you are and how high the blood pressure is. And again, whether you've developed any what we call target organ symptoms. So if it's affecting the brain, the person having persistent headaches, having blurred vision, having nausea and vomiting with it, getting chest pain, getting palpitations, or maybe we do the kidney test and we realize that your creatinine, for example, is going high, then you know that the blood pressure is having an effect. In that case, I'm not going to delay. Or we do the blood test and we also find out that you've developed diabetes. I'm not going to just ask you to walk out with lifestyle. You need medication. So then we'll give you some medication to take.
Absolutely. And my viewers from everywhere else in the world, especially from Ghana, you mean so much to me. I mean, everyone means a lot to me, but especially from underdeveloped countries are really, really important to me in the sense that healthcare is not free for most people. And so going for these MOTs are almost highly impossible for a lot of people.
In fact, for them, prevention is quite important. And we'll come to prevention. Because I don't like medication. I mean, not even paracetamol. No, that's the truth.
That makes two of us.
Yes, if you see me swallowing a tablet, it's almost as if somebody has put a gun to my head.
Is that all? That's true. I don't.
I don't. I would want to take medication for the right reason. So for me, I keep saying that health is wealth. Health is important. Even though I'm still struggling with my family pack, trying to get this Teletubby down.
One pack.
My one pack. I'm trying to get it done. But by and large, the advice is that we should try and stay as fit and healthy as much as we can, so we don't end up on medication.
Let's acknowledge a few more people here. And Gifty Okai, very educative doctor. Olga Armstrong, very informative. Matilda Moore. Matilda, I'm waiting for your questions, you know. Lydia Enyan. Morgan, you are watching. Thank you. Alfred Gatti. Do you know him?
Yes.
He says, thank you, Dr. Khan. Very informative. More of this, please. Alfred, I promise you, we are going to bring you more and more of these topics. And please, don't just watch it. You need to like our page, Omega Live Multimedia, and share our programs. Please take health seriously. Because what we tend to see, especially like those of us in the hospitals, is the worst part of it. And trust me, it really does affect a lot of us blacks. Please take advantage of these sessions that we are doing and bring the questions in. It doesn't matter if you watch it later on. I still have people contact me after the show, and I still have the health professionals happy to solve the problems, and especially for the medication review. Like I keep saying that I had so many people who contacted me for medication reviews. And some I was able to deal with just by going through the session. And those that I couldn't, I refer to the pharmacist, and they kindly review the medications and, you know, help. So please share, like our page. And thank you so much, Omega Live, for this platform.
It's probably at this point that I just wanted to chip in. You know, we've been talking about getting sponsorship. I know there are companies out there, people out there who can easily sponsor the program, so that we can get more professionals on. The whole idea is to educate the community. Most of the people in our community don't access healthcare for one reason or another. And I can understand, because people are busy working. Are you with me? People have to juggle 2 jobs, 3 jobs, and find it difficult making an appointment at the GP surgery. So we want to bring these programs out into the community so that at least in the comfort of your home you can learn something. Maybe you've been sitting by some symptoms, you've not taken it seriously. All it takes is just make a call to the healthcare professional, get checked out before something disastrous happens to you.
Okay, thank you. And Harriet Appiah Anderson, very informative. God bless both of you for giving us the health professionals. I am checking mine now. That's a good idea. Someone is checking their blood pressure. I have slipped with the checking at home, but I do, however, keep up with regular visits to my GP. Keep up the wonderful work. You are definitely saving lives. That is from Harriet Appiah Anderson. June Reed says, whoa, God bless you. Some GPs don't care. A lot of them care. Know yourself as well. But obviously, I can't say they don't. I know majority of people.
A great majority of them.
Who care about this. Linda Victoria Ampofidu Kunti is watching, and she's a Morgan. Rosalie Nanyobode, I have a lot of Infansman old girls watching. And Mr. Emmanuel Kwesi Kwesin, the chairman of the Ghana Union, he was on with you,
for the COVID.
For the COVID. Oredu Jemfi, you are really saving lives, and these health talks are absolutely important. They really are important. Hannah Dikoski, also a senior Morgan, is watching. Edem Brampa, very good program, you know.
Yes, the very good friend of mine, Edem.
Oh, thanks, Edem. June Reed is saying, I never knew MOTs are supposed to be done by GPs at 60 years. My GP complains when I request for routine blood checks. You really have to keep demanding, you know.
You have to.
And Sister Lydia Kwashi, Madam Lydia Kwashi, you are a big fan of the show. I know you are always watching this. Let's go through. I think we have touched on some of the lifestyle changes, did we? Or is there more to add on?
Yes, there is. Yeah.
There is more to do with the lifestyle changes, but if not, we can look at that, finish off with that, and then we look at hypertension in pregnancy.
In pregnancy, okay.
Yeah. So if we can carry on
the lifestyle. So we're talking about management in terms of medication. Now, the medication you're put on, it depends on so many different factors. So once you've seen your GP, investigations have been done, blood pressure has been monitored, then your doctor will then discuss with you the options, which would be either lifestyle modification, and then you come back at regular intervals for us to see if it's making any change at all. But if the pressure is quite high from the onset, then we would want to start medication plus the lifestyle changes, and then we'll bring you back. For example, usually after the first month, we have to bring you back anyway, maybe repeat the blood test, see if you're developing any side effects from the medication we've started, okay, and then see if the blood pressure is coming down. And then depends on what we find, then we may bring you back at different intervals. Is that okay to manage the blood pressure? Where if somebody comes in, for example, like in your case, where it's more than 200, over say 130, and the person has chest pain, they feel dizzy, they have palpitations, they don't feel right, then immediately you want to send them to the hospital. That becomes an emergency because if you don't, if you're not careful, within the next few days, somebody could develop a heart attack or develop heart failure, kidney failure, a stroke out of it. Are you with me? And that could be terrible. So at that point, we act with speed.
That's why I was in the ambulance 3 times in the short space of time.
And then it comes to prevention. We're all growing older, we're all getting busier, we're all leading stressful lives in this country. We can't run away from it. Now, what do? Do we just carry on and not do anything at all about it? What I find distressing sometimes with patients is that sometimes we don't take our health seriously, and then the person suddenly develops a heart attack. Now, the person then goes from not being on any medication to suddenly being on everything. 4, 5, or 6. Because if you don't manage the blood pressure well, and the person develops a heart failure or a heart attack, I mean, you're a cardiac nurse. How many medications do we put them on? You would have 1 or 2 blood pressure medications to keep the blood pressure at bay, another medication to control the heart itself, and then you would have your statins to manage, to keep your cholesterol down, and so many different medications. Then on top of it, we might give you another medication to control reflux, because the medications you're taking is going to affect your acid in the stomach.
Because they may have added like aspirin.
That's right. So that's about 5 or 6 medications. Away, Each one of them has side effects. And then after that, we have to manage the side effects. So patients start from being on nothing, and eventually, if you don't manage it well, you end up on 6, 7, 8. Not to talk about, touch wood, if you had a stroke, touch wood if you had a heart failure, touch wood if you had a kidney failure. These things could have been prevented right from the onset. Health check at 40. After 40, every year, touch base at your GP surgery and have those health checks done.
You see, I know things like breast cancer, for instance, prostate cancer. They are meant to be like age
related. Yes, that's right.
Where they can call you for these. But for routine checks, I don't think they would routinely call everyone because of the numbers, isn't it?
Yes, because of the numbers. So, I mean, years ago, we would send letters to people, inviting them in. Can you imagine? The numbers are millions. How do you literally, I mean, even allowing for resource? How do you get everybody in over the age of 40? No.
Yeah.
Now we want to empower patients. Okay, we don't want to spoon feed people that you're home and then we're calling you to come in. No, your health must be so important to you that you would have to call. Otherwise, then it's become almost like a nanny state. Are you with me? It's become a nanny state where the state is carrying everybody. It's if you look at the amount, the billions that we spend on the NHS, a lot of these things could be prevented if people took responsibility for their own life and their own health. Are you with me? So all that, the message that we are getting out there is that it is not my responsibility to call the patient to come in and have their blood pressure checked. The person should know that, look, part of my lifestyle should be that I have a routine health check. We are blessed to have a free NHS. It doesn't happen everywhere.
It doesn't.
In most places, you pay top dollar to see a doctor. If you've got it for free, why don't you utilize it?
Absolutely.
Yeah. So prevention, and it starts with our lifestyle. We're so busy, you know, where we come from, and I want to touch on this. Where we come from, we think that good living means that you're driving a good car always, even when your local supermarket is 5 minutes walk away. People will drive just to show that, hey, he drives a good car. When you could actually take a bus or go by train. That is walking. How many of us walk even a mile a week? It used to happen to me when I worked in hospital. I walked quite a lot. When I moved to general practice, suddenly the weight started going up. I need my car for home visits, so I was driving to work. By the time you get home, it's quite late in the evening. And then you have your bowl of fufu, isn't it? With your palm nut soup.
Late night eating,
palm nut soup with every kind of animal in that soup. That I call zoo soup. There's pork in there, there's meat in there, there's mutton in there, there's fish in there, there's everything in there. We just eat as if there's no tomorrow.
That's a super high protein diet.
It's a super high protein diet with the carbs that go with it. And then you go to bed straight away. Then you wake up, repeat the same cycle year after year after year after year. No exercise, no dieting, no health check, nothing at all. How can we live that way? Plus smoking, and you know, we love our Guinness. We love our Supermalt. Every meal must go with a soft drink. Why they call it soft, I don't even know. Every meal must go with a soft drink. So we cram in the carbs, we cram in the sugars, we cram in the lipids, the cholesterols, high laden fat. I'm a Fante man. You know how the Fantes do their palm nut soup, and we love to fry things and whatever. Why can't we roast instead of frying? Why can't we eat veg instead of eating all these oily meats and fish and whatever? It doesn't make you a rich person. The funny thing is that when I moved to this country, I noted those who were rich, they lived in rural areas. You know? They don't live in the city.
No, they don't.
And they go to the gym. And they walk a lot and they exercise a lot. Health is important to them. So how come the rest of us don't want to exercise? It is known that for every 10 millimeter rise of your blood pressure, your risk of developing a heart attack and a stroke is 3 times higher.
Wow. We are not doing ourselves any favors.
Not at all. Exercise reduces your risk of high blood pressure. Simply because it makes the blood vessels softer and it works on the heart and allows it to pump blood with less stress.
Absolutely.
That is how it reduces the blood pressure. So the first recommendation would be regular exercise. I mean, the lockdown has been a blessing to many people. People find themselves walking a bit more. There's an app called Couch to 5K.
Couch to
5K or couch to 10K. It's basically couch meaning your chair, your sofa. So getting off the sofa. It's an app that helps you. I've got that app. Now I'm managing to do at least 5 mile walking a week, which helps. My target is 10 miles per week. And the app monitors. If I'm walking, it's monitoring how brisk. It sets target for you. That's several different apps.
And it's just an app you just
It's an app you can just download. You download on your phone and then you set your own. what do you call it? Your own targets.
Yeah.
So, for example, you can decide that every week I want to do maybe 10 miles or 5 miles or 15 miles, and then it will help you to pace yourself. There are different apps, so just download it onto your phone. The phone is not just for social media and for floating all these videos that we like to float on WhatsApp. Are you with me? Somebody could sit down for 2 hours just watching videos on WhatsApp.
Yeah.
But you could go for a walk for 1 hour of that time, and that will be of benefit to your health, basically.
Absolutely.
So walking, swimming, cycling. How much does an exercise bike cost if you've got a small space at home? Or it could also be an extension of your wardrobe, sitting in your bedroom, as most of us do.
Yeah.
A treadmill, you can invest £100, £150 on a good bike. If you can't step out to walk, especially during winter, when you come home in the evening, just cycle. Maybe 30 minutes, have a good aerobic workout. Keep the heart pumping. Or if you've got a staircase at home, okay, just walk up the staircase, one down 10 times. You feel the strain on your thigh and your chest.
And you've had a good workout.
You've had a good workout.
That's easy enough. I think
it's
I
very easy
enough.
So it's just the simple things to keep the blood flowing and to keep the heart ticking. Those little things that we can do. Wow. And then, as I said, diet. Diet is quite important. Okay. When you're young, when you're a teenager, you're building tissue. Your metabolism is faster, it is higher. You're laying down tissues and cells. So if you can eat whatever you want and it's still going into muscle, and once you cross 30, I mean, all that excess eating just gives us more love handles. Are you with me? Weight we shouldn't gain. We're gaining that weight, and once you've gained the weight, it's so difficult.
And unfortunately for us, being oversized like I am, it's sort of good on the eyes when you are in Africa. Like when you live in other places, when you tell somebody, "Oh, you've put on a lot of weight," it's almost like an insult, isn't it?
It's one of the difficult conversations we have in clinic. To open the conversation about somebody's weight, especially a lady, is difficult.
It is difficult.
As soon as you mention the word weight, it's almost like a stigma. So it's a conversation that we find it difficult. Sometimes people think that you have to basically mind your language when you're talking about weight. Are you with me? However, it's a conversation we need to have. Obesity has been implicated in heart disease, diabetes, cancers, hypertension, virtually everywhere. So why can't we talk about diet in a safe way, in an honest way? Are you with me? We love our food. That's fine. Most of our foods are carb-based, isn't it? We love our fufu, our yam, our rice, and it's the portions that are killing us. Because enough is not enough. But you could have a discussion maybe with your practice nurse and talk about diet. Are you with me? More veg, more fiber, more cereal, less kinky, less palm nut soup, less groundnut soup. Are you with me? Let's eat healthier.
It's just everything in moderation, really. Let's see a few people. We will, Dr. Khan, please get ready to look at hypertension in pregnancy. But before we do, people always want to chop my head off if I don't mention their names when they are here. So Linda Ajamine, my BP goes up whenever I visit my GP.
White coat,
that's the white coat one.
White coat,
but please keep an eye on it. We don't know how old you are or what stage or whether you have other things going on. So please monitor, keep an eye on your blood pressure. Louisa Boatingezi says, well done, Doc. Linda Jaman, good program. Sandra Saki is watching. Niyama Saki is watching.
That's my sister-in-law watching from Canada.
From Canada. Wonderful, wonderful. Please share, like our page, start watch parties. Do everything you can, and let's get more and more sponsors for this program, because it's getting very informative, very good people wanting to come and share their knowledge and skills. So please do us the help by sharing, and let's get people watching. We never know, we could save lives doing this. Adwa Dufio Usubanahini says, does apple cider vinegar help? But before you answer that, Dr. Khan, and then look into hypertension in pregnancy, let's do a few more. Obadia Riverson is here, and James Labi. Dear beloved, hope you are doing well in the name of Jesus. Can a media assistant, I think this one is door for us, I don't think It is for us, so we'll carry on. Fitness Pal monitors steps also. I think it's just the
probably an app
you are talking about. And then skipping is very inexpensive.
That's excellent,
Sandra Saki. Yeah, that's a very good point there. Emmanuel Borostone Okwesi is watching. Harriet Apia Anderson is saying we must take responsibility for our health. We very quick to blame our doctors or who the cap fits, but never to do self-check. You can walk and chat, or better get that person also walking if possible. I am really enjoying the program. Thank you. And apparently there's a phone number that you can call in. The producer is saying if you want to call in to ask a question or to clarify, you can call on 0780-262. That's a new one on me. 7333. So 0780-262-7333. Vivian Oriafe says very informative. Harriet Apia Anderson, portions are a problem.
Yes.
Otiba, bravo, blessings, enjoying it. Rose says my auntie, she's tuning in from Takra, the Auntie Rose. Thank you, love you all. And please, let's keep doing this. So before we round off, we will look at hypertension in pregnancy because I think we didn't do that into detail when we did the types and all that. Hypertension in pregnancy. If you can tell us a bit more about that.
Just briefly. In the great majority of cases, most women enter pregnancy or become pregnant when they're a bit younger, isn't it? Without any high blood pressure. Hypertension can either develop before pregnancy, or during the pregnancy. If somebody, remember we did say that the cutoff is 140/90. Now for a safe pregnancy, the blood pressure must be managed below that.
Below the 140/90?
Yes, for a safe pregnancy.
Okay.
If somebody is pregnant and the pressure is more than 140 systolic and more than 90 diastolic, it is not safe for the pregnancy. Not safe for the mother and not safe for the baby. Remember, there's a whole lot of hormones at play during the pregnancy. The woman gains weight because the circulation increases. The cells multiply. There's fluid that is retained. That naturally increases the pressure anyway. So you don't want persistent blood pressure on top of all that when the woman is pregnant. Fortunately, in this country, for example, the complications or the dangers of hypertension in pregnancy, I mean, when I looked at a statistic, it said that only about 1 out of 1 million women who get pregnant will probably die as a result of, say, preeclampsia or hypertension in this country, because it's something taken very seriously. It's well managed and it's taken very seriously. If a woman dies in childbirth in this country, for example, as a result of hypertension or whatever, that's a serious inquiry that will be held. But the same story doesn't apply
everywhere else.
Elsewhere, the standards are high over here. You may have a woman who, for example, had hypertension before they became pregnant. That is normally termed chronic hypertension in pregnancy because they already had hypertension before they became pregnant. If the woman does not have hypertension before they got pregnant and they develop hypertension in the first part of the pregnancy, that is the first 20 weeks, then normally we would call that hypertension in pregnancy. We may use the term chronic as well, but usually that is different from somebody with hypertension before pregnancy. If the woman develops hypertension after 20 weeks of pregnancy and that blood pressure is persistently above 140, especially above 160 to 180, for example, or the diastolic is more than 90, between 90 and 100 or more than 100, then we say they have what we call gestational hypertension if there's no protein in the urine. Then that's gestational hypertension. If there's protein in the urine and the woman is more than 20 weeks of pregnancy and they develop hypertension, then we call that preeclampsia.
Oh, can you go over that?
Yes, I'll go that. Yes, that's right. So we use different terminologies. If the person had hypertension before they got pregnant, that's termed hypertension in pregnancy or chronic hypertension, basically. If they developed hypertension after 20 weeks of pregnancy, that's in the second trimester, for example, and they don't have any protein in the urine, they don't have any problem with the liver, they don't have any problem with the kidney, they don't have any headaches, they don't have any flashy lights or blurred vision, and it's just high blood pressure in the second part of pregnancy, that's gestational hypertension in pregnancy. If they have protein in the urine, maybe swollen face, blurred vision, headaches, swollen feet, abnormal liver function, then you're dealing with preeclampsia.
Very dangerous condition.
Very dangerous condition. And if they develop convulsion as a result of it, then you have eclampsia. So those are the different types of hypertension in pregnancy. Each one is managed differently. Yeah. Now, to touch on chronic hypertension, that is, if somebody already has hypertension. Now, if you look at the risk factors for developing hypertension in pregnancy, it is often said that the older you are before you achieve your first pregnancy, the higher the risk.
Right.
Yes. So, in an ideal world, the younger you are, the safer it is for you to get pregnant. First pregnancies are always a risk with hypertension in pregnancy. So you would see the term that is commonly used as nulliparity. It means that somebody who hasn't had a pregnancy before, are you with me? That increases the risk. If the person is, say, around 40 years and older, when they got pregnant, your risk of developing hypertension in pregnancy also increases. In some cases, even a family history of hypertension increases your risk, especially if you got pregnant at an older age, your risks are higher. And then also for, let's say that I've had a child already, but there was an intervening period of about 10 years between that child and the next child. It's almost
like new again.
It's almost like new again. That also increases your risk. I don't know why, don't ask me, but it increases your risk of developing hypertension in pregnancy. Obesity. It is noted that anybody with a body mass index of more than 35, for example, should you get pregnant, your risks are higher of developing hypertension in pregnancy. And as a result of that, usually, if maybe you do pre-pregnancy counseling before you get pregnant, one of the advice we would give is that try and then lose the weight a little, simply because we know that obesity also has an effect on estrogen, the female hormones, as well. And it increases your risk of clots in pregnancy if you get pregnant, carrying a lot of weight around. So that also increases your risk. I've mentioned age already, and then it is said that, as I said, family, genetically, if there's a family history of preeclampsia, you're also at risk of developing preeclampsia as well. Twin pregnancy, one of the highest risk factors, either twin pregnancy, triplet pregnancy, simply because of the hormone levels as well. It increases your risk of developing hypertension. Now, what do we do? If the woman already has hypertension before they got pregnant, my advice always to the patient is that because you're on certain medications, if you're planning to get pregnant, you need to speak to your GP so that we can change the medication. Because there are certain medications, if you get pregnant on them, it would cause abnormalities in the baby. A medication like Ramipro or Losartan or what people call water tablet, bendrofluazide, for example, can cause abnormalities in the baby. So if you're already on blood pressure medication, you're a bit younger, say between 30 and 40, even in your 40s, and you're planning to get pregnant, if you're on blood pressure medication, please touch base with your GP first, because we would want to change the medication and put you on something that is safer in pregnancy. And then the other important thing is that because you already have hypertension, if you get pregnant, we would have to refer you for specialist management at the hospital. If the pregnancy is uneventful, you're not on any medication, you don't have any medical conditions, then we can safely manage it in the community with the community midwives and the GPs. But if there are other risk factors as well, then we would want the obstetrician to manage this in a hospital setting. And again, it means that because you have hypertension already before you got pregnant, Simply because you've got hypertension, it could affect the baby's growth in the womb. So periodically, they might have to do serial scans, especially after 20 weeks gestation, just to monitor the growth of the baby. If you're pregnant at the moment and your blood pressure is high, take it seriously. Whatever advice the antenatal clinic gives, please don't come off the medication. And I need to stress this. Unfortunately, we have so many of our patients, and I've seen that live with my Afro-Caribbean patients. The worst ones, I'm so sorry to say, are Christians.
Oh, wow.
Yes.
Well, spirituality and everything.
I believe in miracles. But there's a place where you draw a line between practicality and spirituality. The mind is there for a reason. Medications are given for a reason. Yes, I agree. I don't doubt anybody's faith. But I keep telling people that Christ could have commanded the angels if he had decided to fall off that, what do you call it, that high tower. But he didn't tempt God. So don't let us do that. Medications are given for a reason. If you're pregnant, you've got high blood pressure, you've been put on medication, it is there for a reason. Because you could easily lose your life and lose the baby, or you could lose the baby. And then you could end up with a stroke.
And at some point, they may decide to save the mother's life, isn't it? And then terminate
the pregnancy
just to save the mother.
As well. And pre-eclampsia is a very dangerous condition. If you joke with it, okay, if you don't manage the hypertension properly in pregnancy and you develop pre-eclampsia, the patients could develop liver failure as a result of it, kidney damage as a result of it. Some patients with preeclampsia can develop a stroke. Are you with me? It could affect the eye, could affect the heart. So it's not something you joke with, at all. Okay?
You have enough risks just by being pregnant.
Just by being pregnant.
Without an added problem of being hypertensive. So that's like double trouble, isn't it?
That's right,
So it's not something to be taken lightly at all.
In the great majority of cases, once the lady has had the baby, you see the pressure come down spontaneously. However, and this is a word of caution, the fact that you've developed hypertension in pregnancy puts you at risk of hypertension in future. And also maybe cardiovascular problems in future as well. So take that as a warning sign and don't joke. So I tell patients that after the pregnancy, if you've been put on medication, don't suddenly come off those medications. We encourage the patients to come to the GP surgery. We would slowly monitor the blood pressure and we slowly reduce the doses of the medication until the pressure is normalized. And when it's normalized, again, every year, touch base with your GP so that you can have your blood pressure monitored from that point onwards, because your risks are higher. And your risk even become higher when you have a subsequent pregnancy as well, because you've developed hypertension in the previous pregnancy. So hypertension in pregnancy is quite important. My take-home message is that don't joke with it.
Don't joke with it.
Don't
joke with hypertension on its own. But when you have the added risk of being pregnant, don't joke with it.
And when you go
take you out.
And when you go to see the midwives, they would always test your urine, always check your blood pressure. Are you with me? If you're pregnant, you note that your face is getting swollen. Okay, your tongue is getting swollen, your feet are getting swollen, your hands are getting swollen.
And are these like pitting edema?
That's right. Pitting means that when you press it goes in. It goes in. There's a dip, and then it comes out slowly. Or you realize that your vision is becoming blurry and you're pregnant. Seek immediate attention. Fortunately, we have good antenatal care in this country, so most of our women are well cared for in this country.
Fantastic. So I think we have mentioned treatments as we've gone along. And there is a very good question here. Why Ramipril? Daniela Pritchard, thanks for joining in. And she is saying that why is Ramipril not advised for Africans, but rather amlodipine? And she goes on to further say, you can pray, but it is important you take your prescribed medication given to you by your GP or your doctors.
Whilst you wait for your miracle.
You've got to do something in the interim. Right. And Irene Boham, I think on here it says Irene AB, Irene Alomenu, you are also here. And big sister Issy Hammond, as always, she's with us. There are so many of you watching. We are going to round off now.
Yeah.
I think we have been looking at hypertension and even gone further to look at hypertension in pregnancy. Because in Ghana, I did practice as a midwife for 5 years in Ghana. Yeah. And it took people out.
Yep.
And it's a very serious condition. I do know that. So don't get the information here and keep to yourself. Keep an eye and watch. When people are not right or not looking right,
yeah.
you know, just look out for other people,
yeah.
you know, especially your pregnant women. And as we have described, pitting edema, puffy face.
Yeah.
You know, my chubby cheeks is from birth. So
and it's not even for those that are pregnant. Mm-hmm. Maybe you're home watching this program.
Yeah.
You note that your feet are getting swollen. And you're attributing it to the small size of your feet in your shoes. No, if your feet are getting swollen all the time, at least get your kidneys checked, get your blood pressure checked.
Yeah.
Because one of the commonest warning signs are that kidney damage from persistently raised blood pressure. Don't joke with it. Just get yourself checked. If you're seeing anything that is unusual, see your GP.
Yeah, see your GP, very important. See your doctor if you are in Ghana, and give them the whole picture. Don't just tell them you have a headache and it came 2 days ago and that's it. Give them a clearer picture.
Yeah.
The more information they have, the better decision they can make, help you make as well. So AC Hammond is saying, I hope you discuss low blood pressure, but I think you have missed that portion.
Yeah.
So we have spoken so much. We've talked a lot about hypertension, and we did look at low blood pressure along the line. So maybe have a watch party. Beck says, have a watch party after this and watch with your friends. Adwa Dufie is asking about the cider vinegar again. Does it make any difference at all?
I have not done extensive study on cider vinegar. My understanding is that it is good. It has effect on the blood vessels and the circulation. How it works, I don't know. But its benefits have been listed on Google. If you just Google health benefits of cider vinegar, you'll be amazed what you see there.
Yeah.
Whenever there's information on Google, sometimes if it's not evidence-based, I cannot sit on air and then talk about it, because information comes from different sources. Basically, maybe on our next program, I could probably do a bit of reading on cider vinegar and then get proper sources where we could get proper evidence.
The people we are featuring here are proper top professionals giving high quality evidence-based practice that you will have to pay money for, and they are kindly doing it and sharing it with us here on Omega Live TV, Omega Live Multimedia. So please take them seriously, and if we don't have the evidence to back anything we say, we will hold it off. If you have any more questions, please kindly bring them up. Keep in touch with us, and share our page, like our page, Omega Live Multimedia, Omega Live TV. Kind sponsorship by World Remit, and we are trying to get more and more sponsors so we can help out with transport and other things that are coming up with some of the people who want to feature here. So Dr. Khan, do you want to round this off?
Yes.
Before like we bring it, draw the curtain.
I think just a couple of take-home messages. Somebody was asking a question about Ramipril, isn't it?
Yes, Ramipril.
The why
as against amlodipine.
Yeah, I don't know, but a lot of evidence, publications suggest that if you treat people from Afro-Caribbean origin, somebody mentioned the muscle type that we have. You know that blood vessel has what we call smooth muscle, and it's a smooth muscle that allows it to contract.
Yeah.
And it's said that in the African Caribbean people, the kind of smooth muscle we have is a bit different from the Caucasian. Smooth muscle is smooth muscle. However, if you treat somebody on Ramipril from our background, yes, a lot of patients do respond to it, but in the great majority of cases, you struggle with Ramipril. Amlodipine is effective. Amlodipine belongs to a group of medical calcium channel blockers, and that particular group is more effective.
Yeah.
But from my experience, most of our people end up on 2 or 3 as the years progress.
So your wife just managed to get through.
Oh, wow.
Yeah. So that's Baba Isekukan.
Yes,
Yeah.
yes.
She's eventually joined in, and we have somebody, CV Peel Parker. Do you know this person?
No,
It's saying real. I think it's just got to do with all that we are talking about. Thank you for joining in, actually. And Sami Adebiankwa is saying again that Dr. Khan, can you please touch on hypertension and difficulty in breathing? You know, I said that my main symptom at that time was feeling short of breath, which I put down to being anemic because I had been anemic in the past. So what's the relation?
The relation, the heart and the lungs work in tandem. Any problem with the lungs would affect the heart. Any problem with the heart will affect the lungs. Remember, we said that the right side of the heart receives the blood, which is devoid of oxygen, and then it pumps it to the lungs. And then what it does is that it comes back into the left side of the heart, which then distributes it back into the body. Now, if you have quite high blood pressure, for example, in the left side of the heart, then what you have is a backflow. You have blood trying to come from the lungs into the left side of the heart. Now, if the pressure there is quite high, in the system, then basically that pressure, it's almost like it cascades back into the lungs. Remember I said that if the pressure in the blood vessels are high, the heart is going to struggle to pump the blood against that resistance. So if you look at, that red vessel there, if you look on the left side of the heart,
this big tube here.
Yes, that's right. The aorta there. If you look on the left side of the heart, the muscles are quite thicker than the right side. I compare that to somebody going to the gym. The more weights you lift, the bigger the muscles become. If the left side of the heart has to pump against a high pressure into it, it starts getting fatigued. Now, once it starts getting fatigued, if the heart is getting fatigued, you start feeling short of breath. It is the same way when somebody has a heart attack, for example, because the heart is weak, or somebody develops left ventricular hypertrophy or an enlarged heart, because the heart is weak. It is the heart that pumps blood into your body and supplies oxygen. If your heart is weak, the oxygen that is coming in is a bit low, so you're going to be short of breath. So the person says that I walk up just one flight of stairs and I'm panting. I go uphill, I'm panting. I walk just a short distance and I'm panting because the lungs and the heart, they work in tandem.
You may be having an element of heart failure as well.
That's right, heart failure.
So prolonged disease
to the heart as well.
Wow. Incredible. I'm sure you won't believe that we've been here for an hour and 40 minutes, Dr. Khan. That is how long we've been. Viewers, do you want to
just one
more thing?
I mentioned the blood pressure monitor. My take-home message is that everybody should buy one. It's not expensive. £50, it will save your life. Once a week, check it. Best time of the day, you wake up first thing in the morning, when you're well rested, check your blood pressure, off you go to work. If you can't do it, even if it's a weekend, when you're relaxed, you're watching your favorite movie, just check your blood pressure. Just once a week. You'll be amazed. It will be a lifesaver. Just less than £50. If you go to Boots, Superdrug, or even buy it on Amazon, if you can invest in a machine like this, and you can buy a barrel full of pig feet, and that tells me where your priority is.
Absolutely. I think more and more people joined in, but it's rather at the last stage of the show. If you have just joined in, we have had an amazing session looking at how hypertension and the fact that it really does affect us as Black ethnic people, Asian, Caribbean. It's not called a silent killer for nothing. And it is not drawn on anybody's face as they walk around that, you are potentially having high blood pressure. It doesn't usually give any warning. What I would want to say is thank you all for joining in, but you really need to listen to your body. I always emphasize this. Get the checks done. It doesn't matter whether you are in the UK, US, Ghana, wherever you are. Take interest in your body and in all the changes, because it tells you, you know yourself. You see, take control of your body. know how your body is working, and that is why we always start our shows by going into the physiological things, that processes that goes on, the changes that go on, for you to feel the way you feel. So I will say thank you all so much for joining in. Those of you who have joined in late, and you are all saying thank you to Dr. Khan. You have no idea how much he's been helping me to do this show. It is because we all have the same vision, and the health of our people is very, very important to us. If we don't do anything at all, people will die, and it's because we haven't shared our knowledge. And that is why we have so many of these professionals kindly coming on here on Let's Talk About Health through Omega Live TV to share their experiences with us. It is just free, and we take time to explain so that you understand. Even for those who don't have control over the English language, you take time and explain to your relatives, review your medications, listen to your body. The next time we come here on Let's Talk About Health, I have another patient account, and I know this person has watched some of our programs and has been inspired to come on here. So Madam Amma, I think she was my senior in school, and I've mistakenly not taken your new name. So I know you are Amma Folsom. I do apologize for that. But she is a patient who has been going through years of struggle with lupus. Lupus. So she has kindly offered to come here based on actually seeing Mr. Judge's account, the dialysis patient. Coming to give us an account of his condition, inspired her to get the courage and come and talk. You will be amazed at what she's got to share with us. So, Sister Amma, I cannot wait to see you in 2 weeks' time. Thank you all for joining in. Please go back and listen to all that we discussed. It's full of content, and so you don't miss out on anything. Thank you to all the school groups that are watching and urging us on. Thank you to all the nurses associations that are also watching. I think I'm going to make this show such that we can actually do revalidation, watch it and get the notes from it, so it can help us to do our revalidation as well as nurses. So at least we are not listening in for nothing. Thank you. I cannot thank you enough. So until we come back again, remember, this came to you through World Remit's sponsorship and the help of Omega Live TV. We can only think big. We are getting bigger. We are getting better. But it's all because you have decided to patronize us. So on that note, God bless you. And I will be looking forward to catching up with you again in 2 weeks' time. See you. Take care. COVID is still here, Take care.
That's it. Thank you, Winnie.